Why don't we have Brian give his talk? So Brian DeRobertis is Chief of Vascular and Endovascular Surgery at Newark Presbyterian and Cornell, and he's going to talk about catheter-directed thrombolysis versus devices. How do we choose? And I think this will really get the panel involved with a lot of discussion.
Thanks a lot. So that was a great talk, and it really, my talk's going to overlap a little bit with that. The specific title of my talk is Catheter-Directed Thrombolysis versus Devices, How Do We Choose? And I think that last slide that Elizabeth showed really captured the way we think about approaching these patients. There are some patients that are very straightforward, an embolus to the bifurcation of the common femoral. That's a pretty easy case. In other cases where you have extensive thrombosis, in situ disease, there's no easy way to fix those. And so I think that the patient heterogeneity is important, and deciding which approach to use isn't a binary thing. It's more of a reaching into that toolkit and applying different techniques for different patients and also different points along a specific patient's care. So prior to the 1900s or mid-1900s, really amputation was the only treatment for acute ischemia. That changed with a Fogarty catheter shown here, which is basically a red rubber catheter with a part of a finger of a glove attached to it that John Fogarty developed. That was developed in tandem with evolving techniques of surgical bypass in the 50s and 60s that really helped us do something other than amputations for these patients. Now that said, when we were doing doing bypass for an acute limb ischemia, these are extremely high mortality rate procedures, and it has to do with the degree of illness that the patient has from the acute ischemia, but also just their comorbid complications or the comorbid issues. And so there's a number of studies that have shown the very high rate of mortality and even limb loss in patients who require surgical bypass for acute limb ischemia. This paper by one of my ex-colleagues, Dr. Don Barrell, really showed a very high rate of limb loss in those patients undergoing bypass for acute ischemia compared to those patients undergoing bypass for more chronic ischemia. So it's at least a double the mortality rate and amputation rate. So it makes sense that we want things that are a little less invasive for our patients, and potentially something that gives them less of a physiologic hit. And that's where catheter-directed thrombolysis comes into play. The technique, of course, is to cross the occlusion or the thrombotic occlusion with a catheter. Generally, we'll give some TPA in a pulse spray fashion, but usually this means dripping the patient overnight and even several nights. This does require ICU monitoring, assessing labs throughout this period of time, repeat lysis checks, some adjunctive measures, and then ultimately treating the underlying lesions. And the advantages here is that it's a fully percutaneous therapy, can be done under local anesthesia, avoids the morbidity of open surgery, lessens the reperfusion injury because it's somewhat of a slower reperfusion process, can probably improve clot clearance from smaller vessels, and it's applicable not only to acute thrombus, but unroofing these lesions or revealing lesions for underlying disease lesions that need to be treated. So is there a proven clinical benefit? You've already heard a little bit about this. The Rochester trial was one of the first trials to look at the use of thrombolytics. And essentially, all of these trials from the early 90s showed essentially the same thing, generally equivalent 12-month limb salvage rates. Some studies, such as a Rochester trial, showed improved 12-month survival in the catheter-directed therapy group compared to the operative surgical group. And importantly, many of these patients who are treated with catheter-directed therapy first, they do go on to require some type of surgical intervention, but that surgical intervention is generally less severe of an intervention or less procedure that is of less magnitude than the original, than going straight to a bypass. The STYLE trial is probably the most important of these trials. This did include patients with acute limb ischemia up to 6 months. Patients were treated either with open surgery or catheter-directed thrombolytic therapy with a composite endpoint of recurrent ischemia, death or major amputation, cardiopulmonary complications, or renal or vascular complications. And this trial was actually stopped early at an enrollment of 393 patients when I think the goal was 1,000 patients. But I think this was, and this was due to an increase in the relative increase in the meeting that primary endpoint in the catheter-directed thrombolysis group. So it basically suggested that patient had a high rate hitting the endpoint, so it was stopped early for safety reasons. But that said, if you look at the subset analysis of this patient, it was very clear that those patients who had what we consider true acute ischemia, meaning not ischemia up to 6 months, but ischemia of 14 days or duration or less, those patients had a reduced 6-month amputation rate with the thrombolytic therapy. And there was, unfortunately, no amputation reduction with using this type of therapy beyond 14 days. So it really helped us hone in on the fact that for acute limb ischemia, patients with less than 14 days duration symptoms, those patients typically did better in terms of amputation-free survival and amputation rates in catheter-directed therapy compared to open surgery. And again, with those patients who did require some open surgery afterward, they had fewer or a less severe of a magnitude or less invasive surgery compared to an actual urgent bypass. So what are the disadvantages? Already talked a little bit about these: infusion times, high acuity of care, the issue of contrast exposure, radiation exposure, and bleeding problems. And of course, we have a lot of contraindications to some of these to this type of therapy in terms of increasing bleeding risk. So the solution here is to limit our exposure to lytics, or avoid all those lytics altogether by using percutaneous mechanical thrombectomy, or the devices that we're talking about here. So this is just a sampling of some of the devices we have available, probably the ones that are used more commonly here. The angiojet catheter maybe is the oldest of these. The Indigo system, which we've already heard about from Elizabeth, the penumbra catheter, which has really been quite an advance, and then some new devices such as the Wolf device, which was recently acquired by Boston, and the Jedi device recently acquired by Abbott Vascular. Just go over these briefly. You heard a little bit about this already. The angiojet uses a Bernoulli principle to create this vortex to break up thrombus and aspirate much of it into the catheter with a number of different catheter sizes. Penumbra catheter has a very strong aspiration engine that has a lot of force to really suck this clot out. One of the problems with this device is you can get clot corked on the end, as you heard, and that's where the separator wire helps to break up the thrombus. The walk vascular catheter, or now the Jedi catheter by Abbott. This is a similar device to the penumbra catheter, but in the middle of the tip, there's a saline jet that is used to break up that thrombus when it corks on the end. And so this is, I think, somewhat of a game changer in being able to clear thrombus that otherwise would get stuck in that catheter and make it so that the catheter has to be basically removed from the body. This catheter comes in 6 and 8 French catheter sizes. This is an example of one of a case done with the penumbra Indigo system. You can see basically a big common femoral occlusion from a large plug of thrombus that was treated with one of the Indigo devices. Thrombus lodged down to the popliteal. That was sucked out as well, and you can see the final result. So you can have very dramatic improvements and very rapid improvements in perfusion just by using these catheters with the right type of lesion. There is some support for the use of these devices in the literature, but there is not support to the same degree that we had in the 90s with the catheter-directed versus surgery trials. You already heard a little bit about the Pearl registry, 283 patients, 83% technical success rate, half the procedures without catheter-directed therapy as a follow-up. And the conclusion of this study is that basically pharmacomechanical thrombectomy with these devices should be a first line to decrease our reperfusion times and selective use of catheter-directed therapy thereafter. This is a small single-center study at an early study of the Indigo device. Technical success in 70%, and shorter treatment duration in those patients who had a good initial outcome with thrombectomy. And this is generally how I use these devices. For anything that I think I might be able to clear in one setting, I'll go ahead and use one of these aspiration catheters. Try to get a single session procedure accomplished, and if that's not successful, then we sometimes drip overnight to clean up the residual. Another single center study, slightly larger, this is using the angiojet, retrospective study of catheter-directed versus mechanical thrombectomy devices. 49 patients, 2/3 of which were catheter-directed. And basically, this study showed equivalent limb salvage and patency rates at 720 days, with a higher mortality in the catheter-directed group, and also identified some risk factors for poor outcomes in the mechanical thrombectomy group, such as long run times causing renal failure. But more or less, again, each of these trials are showing the same thing: an equivalent rate of limb salvage with shorter duration of treatment times and less exposure to lytics. Finally, one other study looking at both angiojet and Rotarex, same thing, catheter-directed versus pharmacomechanical thrombectomy in patients with acute ischemia, about 100 patients, higher technical success rate in the PMT arm, and shorter hospital stay for those patients effectively treated with PMT. So how do we choose between devices? I think that you need to be somewhat You need to have all of these in your wheelhouse. You need to look at the patient population and what the presentation is to try to decide. And some of what we choose to use depends on the patient presentation, or I'd say a lot of it does. And certainly when you look at the category of Rutherford ischemia, that's the most important thing. Some patients in category 1 can be treated in any number of ways, whereas other patients really need an immediate reperfusion of their vasculature, those patients with some motor or sensory deficits. So this is generally my algorithm. It doesn't really say whether which device we're using, but again, it's sort of guided by the presentation with the idea that we'd like to try to minimize the prolonged treatment times and prolonged exposure to lytics. And some of these patients are better treated with a pharmacomechanical thrombectomy, whereas other ones are treated better with catheter-directed therapy. So I don't know that I've really answered which device we use, other than to say that there's a trend toward trying to go to a single session therapy, and there is some growing data and literature to suggest that this is possible. What we do know is that open surgical revascularization carries a very high degree of perioperative morbidity and mortality. Catheter-directed thrombolysis has been proven to have advantages over surgical revascularization, specifically in patients with short duration of symptoms of less than 2 weeks. And the percutaneous thrombectomy devices really help to decrease our lytic exposure and shorten our treatment times with equal results in terms of limb salvage. Thank you.